Greetings, Sanbanani Apsheni. Welcome back to another episode of Understanding Pre-eclampsia. I know it's a new year, but we are picking up from where we left off. I was actually so encouraged the other day when I checked the comments and someone commented on my previous video and was asking me, when are you releasing part 3? We are ready for part 3. And I was so encouraged. Those subscriptions, those likes, those comments, they really mean a lot to me. So they're not insignificant in any way. If you have a question, please do reach out. It's really encouraging. And also, just a quick disclaimer before we start, remember that these videos are only for educational purposes. They do not constitute as medical advice in any way. If you do need to see a medical practitioner, please do so. I do try to be as accurate as possible and follow all the guidelines that are there, but do not take this as medical advice. So in today's video, we'll be speaking about the management of mild to moderate pre-eclampsia. What is usually done in situations where a woman comes in and she has these elevated blood pressures and protein in urea. Hope you're excited about today's lesson. Let's get right into it. So let us talk about the management of mild to moderate pre-eclampsia. Now remember that it is defined as a systolic blood pressure of 140 to 159 millimeters per mercury and a diastolic blood pressure of 90 to 109 millimeters per mercury. And there should be a presence of protein in urea that is at least this less than +1, or then there should be no organ dysfunction. Remember that this will be based on your assessment, and based on how you see the woman and her condition, you will then classify her as mild or moderate pre-eclampsia. Now, with the management, we will immediately after testing the blood pressure of the woman and seeing that it is elevated, we are supposed to give a stat dose, an immediate dose that is of methyl dopa 1 gram, and then every 8 hourly we give 500 milligrams of methyl dopa. This is before she is transported to a district hospital. Now, a transfer to a district hospital is necessary. This should then be where she will attend her antenatal visits, because women with such risks in their pregnancies are seen at a high level of care. It is necessary that an ultrasound is done in order to determine the size of the fetus, meaning the fetal weight, the fetal parts, and also the estimated gestational age. An umbilical artery Doppler can be done if it is available at the facility. This helps us to see how the blood flow of the umbilical cord is, if there aren't any abnormalities. Now, if the woman is at a gestational age that is higher than 28 weeks, we can do a CTG, with which will help us monitor the heart rate of the fetus. We can also do a confirmation of diagnosis by collecting 24 hours urine sample. That is, we give the woman a bottle where she can collect her urine for 24 hours, and then it is sent to the lab and tested. A full blood count is also recommended so that we can see the platelet count, the ALT, and the LDH. These are the elements that will help us determine if there is any liver injury. Now, if the woman is stable, we manage her as an outpatient. But at every visit, it is necessary to take platelet counts. It is necessary to monitor the growth of the fetus, to check her blood pressure at every visit. And it's also very necessary for us to discharge her with important health information such as her diet. We should advise her to maintain a low salt diet, to take it easy, to rest, to not get herself involved in strenuous activities. We must also inform her about the signs and symptoms that indicate severe preeclampsia. If she is having edema of the lower limbs, she's having headaches, she's feeling dizzy, then she should visit the hospital as soon as possible. Must advise her to monitor her blood pressure regularly. That's if she has a monitor at home, and also to monitor the fetal movements. She can use a fetal chart just to see if the baby is still kicking as normally as it used to. Now, if the woman is unstable, usually induction of labor is advisable at 36 weeks. Induction of labor is when we take a route of making sure that the woman goes into labor medically. So that is it for this week, for this lesson. Hoping that you enjoyed. Please do like, subscribe, and share. Thank you so much for watching.